Hello, ladies and gentlemen, and thank you so much for a new season of Brain Talk. And this time we'll talk about the head trauma. It's called the traumatic brain injury. This is my name here as Dr. Shbranta Alfte. I have any disclosure for this presentation. So we have an important numbers in the neurosurgery. The skull is like, a rigid can that contains around, 1,700, milliliter volume of space. And this is, divided between the brain is 1,400, milliliter, and blood here is also 150 milliliters, and also there is a CSF 150 milliliters. This numbers, especially for a CSF here, is in one time you get like 150 milliliters of the CSF, not the whole day. This is important issue here. This is, the CSF, as we see here. Total volume for newborn is like 5 milliliter, and for adult, as we said before, is like 150 milliliters. For spine and intracranial, this is like 50-50 of the volume. And the formation rate is for newborn is 25 milliliters per day, and for adults is like 450 to 750 milliliters per day. The intracranial pressure ICP for newborn is between 9 to 12, and for adults it's between 18 to 20. So also we have like it's called the cerebral perfusion pressure. This CPP is actually can calculate as MAB minus ICP. The MAB is like systolic blood pressure plus 2 multiple diastolic blood pressure divided on 3. And the normal range is between 60 to 80 mmHg for the CPP. If the pressure is less 60, that maybe patient present with ischemic for the brain. And also we have the Morrow-Kelly principle. This is, we have like brain tissue. The skull is like brain tissue and blood and CSF. If one of these 3 elements, brain tissue or CSF or blood, increase, that's cause, a decrease in other, elements like CSF to compensate, the others increasing of the elements. But if this, like blood increase, they may cause lastly in the last period on the last stage to, compressing the brain and causing what's called the herniation. And also we have a very important issues causing Cushing signs. This is Cushing reflex. When this increase in intracranial pressure, we have a patient have hypertension, bradycardia, and diminished respiratory effort or irregulatory of the respiratory system. Traumatic brain injury is the most causes of this TBI is the fall down, and also the assault by knife or by other heavy object on the head. We also have car accidents also, and bicycles and others causes. We have also another concepts called concussion and contusion and COP and counter COP injury. Also lastly the diffuse axonal injury, DAI. The concussion is like brain has twists and strikes inside the skull. that may have patient have short or sometimes didn't don't have any symptoms, have short loss of conscious, and maybe there is like a physical and cognitive and emotional symptoms. Almost all imaging studies are normal. And we have also here the contusion. The contusion is actually when the brain or the skull or the head of the patient or the for any cause may hit directly, have and direct trauma that's caused like bruise in the brain. So the contusion is called bruise of the brain, is associated with multiple microhemorrhage and vascular disruption and perifocal edema. Other concepts called Cobb and counter Cobb injury. We have like impact on the side of the trauma. This is called counter. It's called Cobb injury. Whereas there is in the same or in the same direction or the opposite direction of the trauma, we have another injury in the brain, and that's called the counter Cobb injury. As we see here in this picture, is the impact or the direct injury on the brain. We have here bleeding, and in the same or opposite direction of this injury, we have also another injury to the brain that's called counter Cobb injury. Location of the brain injury may be same as we said. It's called Cobb. Opposite to impact is called counter Cobb. So lastly here of the our concept, we have diffuse axonal injury. The mechanism is actually called acceleration and deceleration injury. CT, MRI, we see hemorrhagic a focal hemorrhagic in the corpus callosum, brainstem, as primarily. The histopathological is microscopic axonal damage. Presentation: patient having like coma for greater than 6 hours without any lesions or ischemia. As we see in this picture for CT of this patient here, we see nothing for this patient. And when we do like MRI, we see like a focal hemorrhage on the corpus callosum and the brain stem, and here also another one on the corpus callosum of this patient. And this is here is the mechanism of the injury in this diffuse axonal injury. We have acceleration for the the brain in the skull, the brain going in front, and after that the brain is go in the opposite direction posteriorly. That's cause damage to the brain. After this have a discoloration, the skull going in the posterior direction and the brain going in the front. That's make the brain have a very or the axonal of the brain have a injury to these axons. This is another picture for the injury of the brain is in diffuse axonal injury. As we see, this is the skull of the patient going in the anteriorly, whereas the brain is going posteriorly. After that, we have a deceleration of the brain. The brain is going in frontal direction, whereas the skull is going in posterior direction. So traumatic brain injury can be divided to primary, traumatic brain injury and secondary. Another way to define the TBI is closed or opened. We have here the primary and the secondary injury. As we see here, the primary is hemorrhagic contusion, disruption of vessels, distribution of the nerve fibers. Where is the secondary? We have like hematoma, brain edema, and the ICV increase. Also, this is systemic insult like hypoxia, hypotension, pneumonia, and also septicemia and coagulopathy. As we are in this stage, we do our best to prevent patient as develop this secondary damage to the brain. Here is the glaucoma scale. The glaucoma scale is has very important to describe the patient conscious level. We have eye opening, verbal response, and best motor response. Eye opening we have 4 points, verbal 5 points, and best motor response for 6 points. And for mild patient, we have glaucoma scale between 13 to 15, whereas 9 to 12 is moderate glaucoma scale. Less than 8 is called severe glaucoma scale. And another concept for this patient or for brain injury is called brain herniation, condition with tissue of our brain shifting from their normal position to another position and compressing the other structure. We have this herniation syndromes. We have firstly, here is the cingulate falcine herniation, central transtemporal herniation, and ankle herniation, and also these called the tonsillar herniation. Lastly, upward herniation from another mass effect from the posterior fossa. Stage of central herniation starting with this diencephalic stage when the constructed pupils and gaze pulses, and is moving to the below to the mesencephalic stage, dilate pupils, and the pontine stage dilates also pupils and irregular breathing here. And lastly, the medullary stage when the patient is starting to be unconscious and lose of hemostatic control and chain stop breathing and apnea, and lastly arrest, as we see in this picture here, starting from the diencephalon, mesencephalon, pontine, medullary. Oculomotor nerve compression is very important to check it during the herniation syndrome. And when we see this unequal size of these patients, it's called anisocoria. That means we have in the traumatic brain injury, we have like starting the patient have herniation symptoms. Types of brain and skull trauma, we have like 3 types of trauma: the skull fracture, and hematoma, and gunshot wound to the head. Skull fracture, we have a linear fracture and the breast fracture, and also skull base fracture, growing also skull fracture, and ping pong skull fracture. As we see here, this is a linear fracture, typical treated with observational mostly, and here debris fracture. As most of these debris need operation, especially if the debris is more than 1 centimeter or the thickness of the skull bone more than the thickness of the skull bone. And we have a hematomas, duropenetration, and also anemocephalus and CSF leak, frontal sinus involvement. Also there is contamination or wound infection, and for cosmetic also deformity, we must do operation for this patient. And see this picture of this patient, we need to do operation because the breast is actually in the frontal sinus, and there is a cosmetic problem here, and this also the breast is more than 1 centimeter of the thickness of the bone. Also the skull base fracture, we have here the ethmoidal mostly seen. We have also buttress bone fracture or also mastoid fracture here. This is the basilar skull fracture. There's mostly signs to do, to recognize the fracture. Firstly, we have like raccoon eyes. We have a hemotympanum. Also, this ecchymosis is called battle sign behind the ear, and also CS leak. We have here is called rhinorrhea and otorrhea from the air, and also the pneumocephalus. Those all indicators for a skull base fracture. A growing skull fracture for most seen in the child or in children, where these have small fracture in the bone of the skull and starting to grow in, and all the leptomeningeal meninges starting to herniating from the small linear fracture, and starting, to be a very big herniation. And that's the need for, reconstruction of the leptomeningeal and closing the bone. Ping pong fracture is Chinese word for the ping pong, ball that's using in the table, tennis, it's called tennis table. Mostly this is, as we see in the children or infant below the 2 years, and actually treated without surgery almostly, and sometimes you can do operation for cosmetic reason. Hematoma, we have acute epidural hematoma, subdural hematoma, and acute chronic for subdural hematoma, and also hemorrhagic contagion. Lastly, we have a delayed traumatic intracranial hemorrhage. The acute epidural hematoma actually seen mostly of 20% of the severe TBI, males, most than females, and the ages between young people, 20 to 30 years. Source of bleeding is called from arterial, 85% from the medial meningeal artery, and 15% from the venous, actually from the double oblique veins of the skull, from sinus, from medial meningeal vein. The most important, feature that can seen in less than 10 to 27% of patients with this patient have a loss of consciousness. After that, there's improvement, and after that improvement, patient may starting to have loss of consciousness until maybe arrest or death. This is here the medial meningeal artery that may cause, subdural epidural hematoma. This epidural hematoma on the CT, as we see, mostly or almost we see a linear fracture or fracture on the bone. We have something like, a lemon or lens. And this hematoma mostly don't cross the suture. This epidural hematoma, as we see, this convex shape for epidural hematoma, and this is another picture for epidural hematoma. As we see the blood on the dura, not below the dura. Indication of operation volume is more than 30 ml, regardless of glaucoma scores, hematoma evacuation as soon as possible. If the patient glaucoma scale is less than 9 with anisocoria, thickness is more than 15 millimeter with mass effect, midline shift also more than 5 mm is also an indication. This is a formula of how to calculate the midline shift. We draw a line from the inner table of the skull, passing from the foramen of the Monroe, and also there is a line from the inner table of the skull to the septum pellucidum on the side of shift. Here, the side of the shift in this area, and we divide the line here, a measurement, onto minus B. Last here, acute subdural hematoma is mostly seen in the severe TBI, 10 to 29% of the TBI. Source of bleeding is laceration of vessel on the cortex. It's worse than epidural hematoma. High mortality, lucid interval may be present. Most of the patient glaucoma scale is less than 8. Acute subdural hematoma, it's like a crescent or the banana, and this hematoma almost cross the suture. So also, and the shape is concave on the CT. Indication of the operation, thickness is more than 1 centimeter. Midline shift is more than 5 millimeter. CT criteria is thickness less than 10 millimeter, and midline shift less than 5 millimeter. And patient is comatose. Glaucoma scale is less than 9, so you must operate as soon as possible. Chronic subdural hematoma is bleeding around 2 to 3 weeks since initial bleeding, usually in older patient, atrophied brain, risk factor, as we say, all people, coagulopathy, patient using aspirin, warfarin, a low platelet mechanism, initially, small acute subdural hematoma, it's like there is inflammation and fibroblast form a new membrane. This new membrane is starting to oozing of blood and causing chronic subdural hematoma. Here is the acute for subdural hematoma is less than 3 days, and it's like high density. Subacute hematoma 3 to 14 days as isotens on the CT, and chronic is more than 14 days. It's called low density on CT. Indication for operation if the patient have decrease in the level of conscious, hemiparesis, seizure, thickness is more 1 centimeter. Here we have another issue or another concept, delay for traumatic intracerebral hemorrhage. It's usually patient to have small hemorrhage or non-hemorrhage on initial CT. After or within 20 or 72 hours of head trauma, maybe there will be appearance or nearly so on the initial CT is increasing of hematoma. So we must actually, according to the patient situation, repeat or control brain CT for patients. Here also we have traumatic subarachnoid hemorrhage. It's a hemorrhage under the subarachnoid space. It's not different from the vascular subarachnoid hemorrhage. Gunshot to the head is another way, or another injury to the brain. Mortality is 90%. This poor prognosis if the bullet cross the midline or cross the ventricle or cross the center of the brain. Patient also is on the deep coma on the radial hematoma on CT also seen is another poor prognosis. And if there is a suicide attempt, treatment, debridement, evacuation of hematoma, if you can access to the bullet, you can remove it and tight closure of the dura for to prevent infection and prevent also the CS leak. Brain death, as we see, this the definition is irreversible cessation or stopping of all security and respiratory function, and there is a criteria: core temperature must more than 36 degree, systolic blood pressure more than 100, no drug that could influence examination, and must do examination for patient for reflexes, phyllostory, pupils, and also cranial reflex, and also vestibular ocular reflex, oculocephalic reflex, also called doll's eyes, and gag reflex and cough reflex, and also failed to do apnea challenge. All of these reflex must be examined on the brain or suspected brain death patient. The brain death, as we say, patient on coma, there's absence of brainstem reflexes, and also a patient is apnea. This here some quizzes. Here we have pneumocephalus. Here is epidural hematoma, and here we have chronic on subacute subdural hematoma on both sides. We have also here hemorrhagic contusion on the right frontal side and also temporal side. Thank you so much for listening, and we wish to continue our season of Brain Talk in the next episode. Thank you so much.